some shoulder kegels.
Dr. Paul.
Why would she think we would?
So I had a patient who we had seen for women's health issues.
You were 6 out of 5.
And we had done kegels until she couldn't see straight, and then she came in for a shoulder issue, a rotator cuff issue, and I was having her engage her rotator cuff, and she said, "Oh, this is like doing kegels only for the shoulder. These are shoulder kegels." And I went, if it makes sense, let's do it. Let's do it. All right, so everybody grab either a pillow or a towel, something that you can put between your body and your arm. Doesn't have to be very big, just something that will slap you a little bit.
Here, do you want me to set that down for you? Okay.
Because
Usually I'll do
They need a pillow?
shoulder kegels.
It's better, sorry. My pillow ain't good enough for you.
Oh, here, do you want a pillowcase, Amy?
Oh, sure, thanks. Hey, Shelby.
yeah,
You haven't established a relationship.
you do.
I don't know if I'll make it through the whole rest of it, you know,
Yeah,
that.
you don't need to bring in your urinary tract system on the shoulder if they don't already have an
Do you
appreciation.
want me to put that on for you?
Okay, so from this position, if you see the position of my arm, I'm in a slightly abducted position. If I'm completely abducted against my body, that's putting tension on the rotator cuff muscles. Having them slightly abducted is going to put some slack on them, okay? There are a couple of different ways you can do this. The first way, I like to start people with something between their body and their arm just so they're in this slack position and they have something else to give them a cue. I like to then take to the affected side, make a fist, the other hand, just put your palm on that fist. And I want you to think about what we talked about earlier, that these rotator cuff muscles are little fingers that wrap around that humeral head, and they pull that ball into the socket, especially the supraspinatus. Okay? We shouldn't have any shoulder elevation or shoulder abduction actively while we do this. That's part of the reason why I put the pillow or towel here, is if they start to abduct, it's going to fall out, and then we're going to know that they're doing active motion. So all I want you to do is just visualize contracting supraspinatus, contracting the rotator cuff muscles, and just sucking that ball into the socket. You're going to give yourself a little bit of pressure, your palm into your fist, a tiny bit of pressure. That should engage the muscles. You should feel a little engagement right there. And just visualize this happening. There's no lifting, no elevating, no abducting. There's just a little grab of the muscles. That's why it's kind of like a shoulder kegels. We're not really doing a motion necessarily. We're just doing that little isometric, but we're not doing an isometric in any certain direction. We're just engaging all of them. Can you feel some tightening or some tension, or just feel some sort of engagement when you just do that small press and hold? And I have patients do this in front of a mirror to make sure that they are not elevating or abducting. Okay, once they can get it without, or they can get it with the pillow, you can take them away from the pillow or the towel, and again, have them set in a good posture. Hand gives a little press, and you just get that little tension and relax. So the little tension, relax. And you should be able to palpate a little bit of articulation. Delts aren't engaging, so it's deeper underneath there.
The same thing as a setting exercise?
Yes, exactly. Shoulder setting. Exactly. Okay? So that's a very, very basic, if you're trying to get someone to engage, very low level to start them off. And especially people who sublux a little bit, are sloppy. If they're hypermobile through their shoulder, get a little sloppy through there, or they have a tear in the supraspinatus and it's not holding the ball in the socket very well. It's a really good place to start.
Do you also not want the patient to do any like adducting?
No movement.
Yeah, just
No movement. They're not squeezing
Okay.
down on the pillow so
Squeezing.
much. That's just giving them a little wedge, just a little support there. There's no pinch, no lift, no press forward. It's just a slight contraction. Okay, so that's the beginning. Shoulder kegel just to start engagement. Then you can move into isometrics in all planes. So we can do every different direction. I can have someone do flexion. I just have them usually make a fist. They can do a long lever flexion or a short lever flexion against the wall. Okay, so just pushing forward or lifting forward. This one, long arm, long lever, is going to be a little more challenging. Okay, then just punching forward, punching straight back against the wall, or long lever arm extension. A V-duction. You can go out to the side, or again, short lever. Press against the wall, all the different directions. Internal and external, they can use their other hand or use the wall in the door jamb. So I'm in good position. I'm going to resist going out into external rotation. I can resist going into internal rotation. So all the different motions of the shoulder, we can do isometrics, typically short lever arm and long lever arm. I have a quick little exercise routine that I'll have people do sometimes where they don't have to change positions, but I'll just have them make fists, and they can push their fists into each other. Then I'll have them go on top, and they're pushing into each other. On the bottom, they're pushing into each other. One on front, they push into each other, and then behind, they push into each other. And you get pretty much all the different directions by doing that. So sometimes patients will get confused and, maybe I don't want them spinning in circles. Maybe they have a little vestibular issue and I don't really want them to be standing and pressing and tripping or anything like that. So I'll just draw them a little picture with fists. Just press in, press on top, press on bottom, press on front, press behind, hold each of those 5 seconds or so, and they can go through that a couple of times. All right, P and F, alternating isometrics by the PTA. So I had Brian down in position here in external rotation. We talked about alternating isometrics in flexion. You can do all the different directions. Thank you. So if we wanted to, let's do flexion to start off with. So we talked about alternating isometrics. Brian's going to lock his shoulder in position. He's going to hold. You're the Statue of Liberty on the wind. Don't let me move you. So we can come through and give little perturbations. And I say, hold it, come on, don't let me move you. Come on, hold it still, don't let me move you. Hold it still. I can mix up my directions. I can make it harder and have him close his eyes. I can mix up my timing and just have him hold. Typically we're going to do this for a timed duration, 10 seconds, 20 seconds, 30 seconds. This will be strengthening in 90 degrees of flexion. If we want to strengthen in other degrees, we have to actually do this in other degrees. So I could have him come out of 90, have him hold the elbow still, but we're going to go a little bit higher than 90 and do the same thing. I can have him go a little bit lower than 90 and do the same thing. It's going to be easiest here at 90 because gravity is pulling straight down. He doesn't have to do as much work to hold it. It's going to be harder above and below or outside of 90. Okay, so by doing this, we're getting a co-contraction of all the rotator cuff muscles, all the stabilizers. We can also do in other motions, so I could have him here. So he's working more internal and external rotation. Same concept, I can have him at 90, then I can take him out of 90, either above or below, and hold those positions. And I'll just have him hold it still, don't let me move you. I'll come from different directions. I can have him close his eyes. We can progress it that way, have the patient have to hold for a longer duration while you're doing it, changing up your timing and your speed. Okay? So alternating isometrics. Thank you. And then band-resisted isometrics. So patients will get bored just doing isometrics. And if someone is, especially post-op, there may be 6 weeks when we can't do anything in a range of motion or active. It's only passive range of motion, and then you can start isometrics. And that gets so boring. And then jumping from isometrics into moving through range of motion is a pretty big jump. So you can go in between. I learned this from a great local therapist. It's a band-resisted isometric. So I would put my loop in the door.
Retreat.
So instead of pressing against the door and holding it, I can hold onto my band here, I'm locking my shoulder into position, and I can walk forward. I'm not doing any range of motion, but I'm progressively gaining more resistance as I walk forward, and then less resistance as I walk back. So I'm gradually pulling resistance on and off. But the joint is safe because I'm keeping it still. I'm not actually going through a range of motion, I'm holding it still. We can do it in a short lever arm as well, so I could hold here, do the same thing. So I could do flexion. If I turn around backwards, I can do extension. So I have to pay attention to which direction my band is. So here's my extension. Again, I could do a short lever arm to start off with, so it's not quite as hard. I can do abduction, side step. And I could do abduction if I wanted to, typically don't. And then I can do internal and external. So if I'm standing with the band to my left, using my right shoulder, and I'm stepping away, which muscles is this working?
External.
My external rotators. I'm holding them still. I'm trying to resist doing any bit of movement. And so I'm working my external rotators there. If I turn around the other direction, locking everything into place, sidestepping away. Now my internal rotators are having to resist. So that's a nice intermediate step between just regular isometrics and doing a band exercise where you're going through a range of motion. So this is a safe progression that's not going to put the tissues in positions through a range of motion, or especially if they've been surgically repaired or there's a tear or something in there. It's a nice, easy transition into more progressive resisted exercises.